After a few, a couple of months, I think, of us missing some sessions, welcome to the Value-Based Healthcast, a showcase for new ways to deliver healthcare that aims to improve accessibility and outcomes for all without breaking the bank. I'm Nick Wilkinson. I'm a paediatrician specialising in rheumatology and chronic pain with an interest in setting up new services. And
thanks, Nick. I'm David Hanna, a paediatrician as well, and I work in paediatric emergency medicine here in Cardiff. So today's session, we've got two fantastic guests. We've got Dr. Isla Kosh, who is a GP, but who also runs Cardiff and Vale Health Inclusion Service. And Isla's going to be telling us a bit about her service, what CAVIS does, how it got to be where it is, and what her plans are for the future. We've also got Ivana Wong, who is a community pharmacist in the Cardiff Southwest cluster. The Cardiff Southwest is known to be a bit of a hotbed of value and innovation, particularly around the community and social prescribing. So again, we're really looking forward to hearing from Ivana, who's going to tell us all about the work she's been involved with. How the Value-Based Healthcast normally works is we'll hear from both of our guests, and for people who are listening or viewing, if you want to ask questions of Ivana or Isla, then if you pop the questions in the chat bar or in the questions feature, and then Nick and I can pose them to our guests as we go along. We really encourage you to ask any questions of Ivana and Isla, because we found that really stimulates conversation and takes us all kinds of places. So without further ado, I'd like to introduce Isla Kosh.
Hello, thank you for having me on. So shall I tell you a little bit about what I currently do? So I'm Isla Kosh, I'm a GP. I'm currently the clinical director for Cardiff and Vale Health Inclusion Service. So we are a fairly new service that, we rebranded from an old service about 3 years ago. So previously we were known as Cardiff Health Access Practice, and that was a service, a health board run service that was resourced to provide health screening for newly arrived asylum seekers. And under the management, there was also the alternative treatment scheme for individuals who were banned from normal general practice for violence or aggression. So then they would come into the service with security to be seen once a week. So that's what we were. And then I sort of came to post probably 3.5 years ago now, and we looked to try and widen what we could offer. So as well as just offering health screening for asylum seekers, we wanted to broaden that to also offer it to people coming via refugee resettlement schemes, so the Afghan and Ukrainian resettlement schemes. We wanted to broaden our offer to other health inclusion populations as well, so not just refugees and asylum seekers, but to recognise that there are sort of 5 main groups really who have the worst health outcomes. So those would be high needs homeless people experiencing homelessness, refugees and asylum seekers, people engaged in sex work, people just released from prison, and people who belong to Roma, Gypsy or travelling communities as well. So the data out there is that they have the worst health outcomes. So we wanted to really start on this journey of developing a health inclusion service to target care, a different model of care to these groups that find it very difficult to access our traditional models of care. And currently, due to that difficulty in accessing, the health inequalities are widening, really. So we wanted to try and redress that. And health inclusion as a concept in itself is about it's a research, service and policy agenda to try and redress the extreme health and social inequities that currently exist. So we wanted to be part of that in Cardiff and Vale. So that's sort of where we've come from. I can tell you a little bit more about where we are. Or
please, no, carry on. Yeah.
So at the moment, what we're currently providing, as I said, is public health screening and health screening for asylum seekers, refugees, people with no recourse to public funds, or people who have sort of been destitute and sort of under the radar, and they might pop up and they'll come to us. We'll give them health screening. And also we provide via our third sector partners a holistic needs assessment as well. So many people come who are in the asylum system but don't quite understand it. Their access to money, clothes, places to go, it's a very confusing system. So they need advocacy and support with that. So we're co-located with British Red Cross, and it's sort of a seamless transfer between the health assessment to the Red Cross holistic assessment. We also provide outreach, GP and homelessness specialist outreach to some of the high needs hostels in Cardiff. So 5 mornings a week, we have a GP going out with a nurse, and they run a drop-in clinic. So anyone can turn up at any time, because we know that part of the barrier to accessing care for these individuals is very sort of rigid, tight appointment times. And so these drop-in clinics tend to work better. So at the moment, these patients or homeless people still retain their GMS registration, because the point of this current effort is to try and reduce EU attendance, because we know from the data that lots of people who are homeless use the EU to access healthcare, because getting into GP practices is difficult because the lifestyle doesn't match with the traditional model of care for those that are very, very vulnerable. So that's been quite successful. The data we've had from that has shown that we've been able to reduce EU attendance by treating people there and then in the hostels and giving them what they've needed. And for those who definitely do need admission, we've been able to bypass the EU and refer them in directly, which is obviously good for the EU. So that's one element. The other element, we're still running the alternative treatment scheme. So that's for people banned from other practices for violence and aggression, because actually that cohort of individuals often come from very traumatic backgrounds, and there's a lot of crossover with homelessness there as well. So that's where we are at the moment. We are looking to try and expand. So we're working really closely with Cardiff Council and third sector colleagues to look at what the vision for health inclusion is across Cardiff and Vale. And we have a business case which we are phasing into 3 phases. So our first phase is about looking at developing the outreach provision that we're currently doing. So we'd like to maintain our homeless outreach clinics. We'd also like to start up clinics in probation services, so targeting individuals who are under short-term sentencing probation. So these are individuals who are in and out of prison quite rapidly, with rapid turnover, often breach probation, lots of substance misuse, and they're never really around long enough anywhere to register with a GP or keep an appointment. And so they don't really have access to that preventative care. So by going into probation sites and working closely with colleagues in probation, we'd be able to almost run a one-stop shop type approach, where the co-location would lead to that opportunistic screening, vaccination, treatment of health conditions. So that's one outreach we're looking to do. So that's men's and women's probation. And then we're also looking at potentially going into sex parlours and offering screening as well, recognising that many sex workers are undocumented as well. So then often are scared to register with primary care, are scared of immigration, not immigration, but are scared of popping up above the radar, basically, and potentially being deported. So we have to take healthcare to them. So that's what we're looking at doing in the phase 1. The other thing we want to do in phase 1 actually is to put health inclusion nurses up at the EU, which we've got at the moment. We've got that about 4 days a week. And the idea of those nurses is to catch people who are homeless that turn, or, potentially very vulnerable asylum seekers, catch them when they turn up at the EU, and to see if there is anything that could be done there and then opportunistically with regards to screening, vaccination, contraception, to make sure that if people are discharged, then they're discharged to support. So we don't want people discharged into homelessness. I know that's very difficult at the minute with housing crises and other issues, but looking to really join up services so people aren't just discharged from the EU onto the streets. Also looking at this nurse going onto the wards and liaising with the discharge liaison team about the best way to discharge people, to reduce bed stays where there's no need to have lengthy bed stays, but also to make sure people are discharged with support in place. So that's phase 1, and we're going to be waiting over the next couple of months with bated breath to see if that's been successful. Phase 2 involves, new buildings, another business case. And I did enjoy, I think it was you said, Dave, value-based healthcare without breaking the bank. I'm not sure that anyone would say I'm not breaking the bank at the minute with the ask, but I think, in 50, 60 years, it might be, the evidence that this is financially more sensible will probably come to light, but obviously it's a short-term investment, isn't it?
And I think you're right there. It's not about the setup costs, because they will all basically you're spending to save.
Yeah.
And so it's all of the downstream effects that you're hoping to avoid. So when they're older, future admissions, and as well as immediate distress.
Mm, mm.
I was just fascinated, Isla, by what you were talking about in terms of moving care, because we know that hospitals do probably far more activity and things than they should be doing or need to do. But that's because often there's no other options and people come to hospital because there is no other place. But what you're talking about is going upstream, and you're going out into the community and you're preventing, you're offering something else to people, an alternative way of obtaining healthcare. That can be a really difficult sell, I think, because as you said yourself, it can be a long-term win in terms of finance or funding, even though it's the right thing to do. And how have you managed to win support for the new things you want to do?
It's a very good question. It is a really hard sell in the current climate. I agree. So in terms of the story of how it started, so when we came into post and you sort of realised we wanted to expand the service, what I practically did was to try and engage everybody that I knew who was working with people who were traditionally excluded. So contacted, colleagues on the BBV team, colleagues in the council homeless team, third sector colleagues, just public health colleagues, just to start a discussion, almost like a discussion group really, of what some of the issues were, what we thought the solutions might be. I just wanted to get everyone in the same room around that to start a conversation. And then that probably went on for about 6 months of regular meetings. And then Fiona Kinghorn, who was the then exec director of public health, became our exec sponsor. And she allocated one of the registrars to write a health needs assessment for us, which was really pivotal in the start of this journey, because to that point, there hadn't been any local health inclusion needs assessments done. And there is such a paucity of data around these health inclusion groups across the board. So primary care, secondary care, they're the truly unseen. And so it's not coded often when they come into the EU, who's homeless, who's a refugee, who's an asylum seeker. It's really actually difficult to look at how the frequency of attendance, the length of stay, what the cost is, it's really, really difficult. So actually to start with a health needs assessment, look at what the groups were, look at what are a bit of mapping and what other services were working in Cardiff and Vale to address some of these issues. That was a start. And then we presented that health needs assessment then to the UHB exec board, and and that presentation went well, and we had a lot of buy-in. Suzanne Rankin and Paul Bostock were very supportive, and then that led to the setting up of our Health Inclusion Programme Board. So that's a board which Paul Bostock chairs that, and we have on that board colleagues from exec level from Cardiff Council and third sector. And the point of that board is to, unblock the blockages to the progression of this vision, and to sort of give direction to the operational group working below that level to try and get the vision implemented. And that's been really, really helpful. It's brought public services together really to look at how we can address this problem together, because it's wider than health, isn't it? Health inequalities are wider than health. Actually, health is a very small part of health inequalities, isn't it? And the solution has to be wider than health, and the responsibility is wider than health. And so the bringing together of those public services has been instrumental and will be going forward to how, to if this is successful or not, really.
Something, just going back to what you mentioned there about the coming into post, spending 6 months exploring and building those relationships and getting people together. That's really interesting, because it sounds like you did that first rather than coming in with a firm plan of the service design. which doesn't
Yeah.
always happen.
Yeah.
But it
Well,
sounds like maybe you gave people the opportunity to be in the room and contribute before actually a vision was decided. Is that how it was?
Yeah. Well, I think I just recognise that I don't have all the answers. People have been working, a lot longer than I have in these areas. Maybe not doing the same role, but lots of experience in other roles. And I think it was helpful being fairly new, so I could come in and say, "Look, I'm new. This is the problem that I see that Cavis faces. How can we work together to try and make it better?" And I think that, I've been very grateful to have learned from so many other colleagues in third sector, local authority, and in health about how we get this done, because everybody comes with their own experience and point of view. And so this really has to be an integrated project in a way. No one person or one service has got the answer to this. This is about partnership working. So I think partly that happened, Dave, not because it wasn't a sort of an intentional play. It was because I really was new and I didn't know what the answer was.
I mean, there's so much you've shared already, but can we just get into a little bit of the sort of the nuts and bolts? Well, you said, or you obviously had to make a case. So how many patients are you seeing? Can you give us an idea of that? Or patients, I mean, people are you seeing? And what sort of staff involvement? Because it's very holistic what you're describing, and obviously you're covering sexual health, you're covering mental health, and homelessness, all of that, which might be all with the same person. So how does it work? So what sort of numbers and what sort of staff and how does it get done?
Yeah, so numbers wise, so with our refugee and asylum seeker stream of our service, it's a constant turnover as new people come into Cardiff. New people are placed in Cardiff by the Home Office. So Cardiff is one of the Home Office initial assessment centres. I think there's 9 across the UK. Cardiff is one of those. People will be placed in Cardiff by the Home Office. It might be any time from about 2 months to 6 months. Some of them it's years, and then the Home Office move them on to sort of more permanent accommodation. So we get a core number of people that might stay in Cardiff, but then we get a lot of churn around that, which creates a lot of the work with the screening. So roughly on our books with asylum seekers, I think at the moment it might be around 2,000 off the top of my head. I'd have to go to our operational manager to get the exact figures.
Okay.
It's about that. Then with the high needs homeless or the more complex homeless, roughly it's about 800 to 900 in Cardiff. And then we've got rough estimates of sort of vulnerable or street-based sex workers. It's about 400.
Yes.
And people leaving prison on short-term sentencing, it's about 300 to 400. So the numbers go up and down. So when we get refugee resettlement programs, the numbers go through the roof, and then we have to respond to that. And then they might go down as that settles, and we've worked through backlogs of screening. So at the moment we are, with the arrival of Afghan refugee families that have worked with the British military arriving at St Athan MOD site, Cavis is responsible for providing that screening and healthcare until they're moved to permanent accommodation. So our numbers has been a real problem with writing our business case, because it's never the same. It's up and down all the time. You have to look at the numbers over a 3 to 5 year period because it's so variable.
Okay.
Mostly adults, I would say. So mostly male. So as people seeking asylum that come via irregular routes are mostly male, but we do have quite a lot of asylum seeking families as well. So we do have a proportion of children as well, but it would be mostly single people rather than families. You get more families via the refugee resettlements. So numbers are really hard. Staffing, since we've over the last sort of 3 years have developed a little bit. As I said, we've got Red Cross project support workers that work providing support and sort of holistic assessment. That's been great.
Does that help then with communication? Because some of this will be fear of authority, won't it? In some of the people you're managing, and so doctors might represent that. Do you? I asked that because a good friend runs Well Centre in Streatham, which is for gangs, and so they use youth workers an awful lot. Do you find that you have that similar relationship with charities? Just you mentioned Red Cross.
Yeah, definitely. I think British Red Cross, it's an internationally recognised organisation, isn't it, with the emblem? And I think that gives people confidence that we're trustworthy. I think what also helps is we've developed our invitation letters very sort of practically to be translated into people's languages. So someone will receive a letter in their own language, which tells them exactly what the point of our service is, tells them that it's all completely confidential. Nothing is going to be reported to the Home Office. This is about health and purely about health. And that we have British Red Cross on site as well. And so I think that's really helped people to feel comfortable. I think also it helps that, people come in to see the British Red Cross who may not be registered with us, but now they've heard that British Red Cross are based here, they will walk in to try and access them, and the British Red Cross support officer can bring them down the corridor and say, look, this is my friend who's a GP here, they can try and help. And I think it's just vital, those sort of cross-sector partnerships with these vulnerable groups, because delivering healthcare to these groups is all about trust, and if you haven't got that trust, it falls flat.
Yes.
I can see that Alex Hicks, who's listening online, had some questions around adults and children in the service, but it sounds like you've answered some of those, Isla. Something I'm interested to know is, how do you take something like Cavis, which probably began life as an extra service responding to a need that maybe wasn't quite clear at the start? How do you make that business as usual for the health board so it just becomes part of what we do?
Yeah, that's a good question. I think so. What's been helpful has been benchmarking with other services across the UK, because we don't want Wales to be left behind, and health inclusion work is being done across the UK in various guises, because I think Cardiff is ideally placed size-wise to not be too big to make this unmanageable, but be big enough that it has these 5 inclusion groups in it. So there's plenty of work to do. So I think it's partly saying, look, this is going on here, this is going on there. What are we doing to address that problem? I think, health inequalities and the widening of those is a huge issue. And I think every public body would want to have that addressed, and it's in the plans and visions of lots of boards and public bodies. But I suppose I feel that Cavis is a very small part of trying to address that in a very practical primary care type of way. So I think part of making it business as usual is presenting, look, we have this problem across our city. This is the problem for health and local authority. And here is a partial, not a solution, but a working towards making it better. So it has to be business as usual, because this is a problem that's not going away.
And thanks for that. And I wonder, just thinking back to the Health Inclusion Programme Board, I think having something like that with leadership from a very high level across different organisations must help as well. How did that come about? Was that something that you had to push hard for, to have that high level group?
Well, it didn't feel like I had to push hard. I think, we presented our health needs assessment to the CAV UHB exec board meeting, and I think part of what was helpful with that was presenting patient stories and actually presenting the data. So you basically go and you tell the truth, don't you? This isn't this isn't like a business hard sell or trying to manipulate people. This is telling the truth. So I went and I presented the average age of death for a homeless man is 43, and the average age of death for a homeless woman is 45. This is my age. This is appalling, and this is happening in our city now. And also telling a few stories of how people basically fall between services, and how the system we've got is not adequate, it's not equitable, and it's actually not just. And we need to move towards systems that are more just. And, in the spirit of, proportionate universalism, there has to be a change. And that's not what we've got at the minute across primary care. And so I think it was just going and saying that really, started the programme board. But as I said, Suzanne Rankin and Paul Bostock were very, very supportive, and it hasn't been hard to get engagement.
And just before we move on, it was just coming back to the question about the sort of the level of staffing that you do, and obviously you're working very closely with other charities. which you obviously will have to. What can you give us a sense of sort of how many staff will contact, or are you delivering everything through the one person who then just has a broad set of skills?
Yeah, that's a good question. And as we develop the service, what we are trying to do is broaden the skills that each of us have to make every single contact count, so you can get as much done in one contact. We're still on our journey with that. So I suppose to be co-located with services helps that as people skill up, doesn't it? Because you can say, look, don't go away. If you just wait 2 minutes, next door is so-and-so who will give you your take your bloods and, give you your smear and your LARC injection, all of that. So there are lots of different services that people are involved with. So third sector, as I said, the GPs, the nurses, the health visitor, the midwife, we've got all of those on one site. We've even been working with our physio colleagues who now come into Cavis and they deliver a physio clinic from our department. And we've also, one thing I didn't mention actually, which has been absolutely brilliant to the development, is we've been working with infectious disease colleagues at UHW. So when we screen refugees and asylum seekers, we screen for BBV and, strange parasitic infections. And then we were finding that we'd be referring them up to UHW. The DNA rate was astronomical. So then these people would be moved on across Wales with untreated hepatitis, untreated schistosomiasis, and then would potentially be lost out there. And so I had a conversation with Baz Ali about what we could try and do about that. And she was fantastically flexible and said, well, why don't we come to you and we trial for a year, pilot basically a co-located ID clinic, and the DNA rate has dropped and we basically don't get DNAs. And when we do, the Cavis admin team just chase, give letters in their own language, use interpreters until we get them. And people come to the clinic, the medication is dispensed in the clinic, and it's a one-stop shop, and that's been just brilliant. We've treated loads of parasitic infections and hepatitis that way, so it's been a really exciting development. So yeah, as people have lots of contacts with lots of different health professionals, and obviously that's needed in many circumstances, but we are trying to skill up to make us as broad and as flexible as possible.
And are you using IT or apps to track? Because one of the problems I found with some of the care of the services I deliver, trying to track where patients are going and whether they do have that contact. How are you managing that? Do you have a resource for that, or is it just asking them?
I suppose that's like the most depressing part of the development is the IT at the minute, and how systems don't talk to each other. And that's a real challenge. I've just actually come off a meeting before this to talk about the harm reduction database, which is a database to collect when someone last had BBV screening, are they using needle exchange? And there are so many different systems that we're currently using that as we go forward and develop this service, we need to do a little bit of a streamline and almost have a central point where we can go to for all the salient information, because we can ask people and they'll tell us what they know. But often, it's such a confusing system, the NHS, for so many people. I mean, a lot of the people we see have never even been in a hospital or seen a doctor or a nurse ever. And then they're exposed to the NHS with all these multiple departments, referral letters, ring. If you don't ring within 2 weeks, you're going to be off listed from the clinic. So actually even asking them where they've been or what was done, sometimes it's difficult to get the full story. So we do an awful lot of ringing around. So our admin team are brilliant at, phoning appointments, phoning specialty secretaries. There's just a lot of behind the scenes work to try and chase down where someone is in the system. And that's all unseen work. And often that's, when you're looking at, what whole time equivalents do you need in an admin team for a service, all that work has to be factored in, the chasing, because without the chasing, these groups don't get the care that they need at the moment.
Well, thanks, Isla, and thanks for a fantastic insight into the service you lead. I know that there are another couple of questions which we probably don't have time for right now, but before we move across to Ivana, I might just leave you think about this one. And Ashley McLaren has asked whether there's been any evaluation of the service so far and whether there's been a reduction in emergency department presentations. But I won't put you on the spot now to answer that. I'll just let that sort of ferment, and so we'll hopefully have time to come back to that towards the end. But next, I'd like to introduce Ivana Wong. Ivana is a community pharmacist in the Cardiff Southwest Cluster. And the Cardiff Southwest Cluster, for those of us who work in Cardiff and Vale, has developed a bit of a reputation over the last 10 years for doing some really interesting things around primary and community care. Some of that led by GPs, but some of it led by non-medical professionals and allied health professionals too. So I'm going to introduce Ivana. Ivana is going to talk to us a little bit about the work she does as a community pharmacist, but also some of the particular projects she's been leading and involved with. So Ivana, over to you and welcome.
Hi, everyone. Thank you for this opportunity. I'm so excited to come and share what is dear to my heart, my passion about patient care and patient safety. So can everyone hear me okay? Yeah, I'm going to show you my slide presentation, slideshows. Right. So hopefully this is going to work. Right, sorry. Okay.
It's okay. We'll get there.
Okay.
Perfect.
Is that working now?
It is maybe presentation mode and we'll be there. Perfect.
Yeah.
Ready to go.
Lovely. Ready to go. So my name is Ivana. I'm one of the cluster pharmacists working in the Cardiff Southwest GP cluster. So we cover the 9 GP practices in this area. So the project that I'm going to talk about today is about improving DAL, improving patient safety, and reducing medicines waste through pharmacist-led, cluster-based, post-hospital discharge medication reconciliation. Right. I would like you to imagine this. So this is a picture of my 100 years old grandfather. So he just came out of hospital and then after a prolonged stay, and he came home with a whole bag of medication. And he was quite confused, because he wasn't given any letters or anything to say how to take them. And then he also have another bag of medication at home, which he was taking before he went into hospital. And then he roughly remembered in hospital, someone said to him, he needs to check some sort of reading every day at home and then pass it to his GP. It's just too confusing to him. And then he's like, he doesn't know what to do. Okay, so this is quite a classic examples of patients that we sometimes see after in the GP surgery after hospital discharge. So a bit of a background. So we have a Cardiff Southwest Cluster Integrated Care Hub. So we have been supporting patients discharged from hospital. And then cluster pharmacists have been undertaking medicines reconciliation for all patients discharged from hospital since September 2020. And we have found that issue with discharge advice letters, DALs, which I'm going to use a lot of DALs later, can cause increase of patient harm risk and increased potential hospital readmission due to medication errors, communication issue, which result in increased healthcare professional workload. So the issue identified actually span the primary and secondary care interface and impact on patient safety. So aim of the project is to improve the quality and safety of transition care between secondary and primary care and monitor medicines wastage in this context. The objectives were to spread the model to 2 other clusters within our locality, to use this spread and to collect data on DALs related errors and incidents of medicines wastage, and hopefully inform improvement work within the health board to improve the reliability and safety of DALs. So we initiated the spread and scale by engaging 2 other GP clusters within our locality. We went to their cluster meeting, we did some presentation to share to them what our model was, how to do it and things like that. And we successfully enlisted the North Cluster. And then, so as cluster pharmacists and our project support worker, as project support manager, met up and then work collaboratively to facilitate a setup process, and then the data collection. And then this new model was implemented across 2 sites, one in Lansdowne Surgery and one in the North Cardiff Medical Centre. And then to assess the impact, we've also done a comprehensive set of outcome measures. So here are some outcomes, which is the interesting part, right? So we, the new model started in our cluster, and we then recruited another additional cluster. So throughout May to December 2023, we actually found 11,823 patients had a pharmacist-led medication reconciliation. And then we actually managed to collect some data on analysis of number and types of safety issue mitigated, with 98 DATEX reported. And then we managed to have 107 items of medicine waste reduction and cost savings. And then while we were doing our project, a further cluster in another locality adopted the same model, but we haven't included in our data collection because it was after we finished our data collection. So it's these are the things that we've noticed. And then here's a table which shows the difference between North and Southwest. So Southwest, we have started it first, and then North are the one who joined us. And then we also had examples of issues which we have identified and mitigated. Some of the examples are suboptimal dial information, for example, like missing dial, late dial is not being signed off. And then we have an inappropriate request for GP action, for example, for GP to prescribe hospital-only medicines. And then prescribing errors, for example, like drug interactions, contraindication, incorrect dose. And then the other part is the discharge medication supply issue, where, for example, patient has been discharged home with medication been stopped, or there's dispensing errors and things like that. So the impact. The project has achieved a significant process improvement, because our old process involved the MedRec done by admin staff and GP, which involves a lengthy multiple steps, and then it could take up to 7 to 28 days before the correct prescription is being issued to a patient. What's the new process? We do it centrally in the cluster care hub, and then the reconciliation part is done by a pharmacist. And then we ring the patient, we follow up all the changes, we make sure the prescription is done, and it became like a same day one-stop shop. So not only it's quicker, it also has this added safety check by pharmacists. And some impacts that we've noticed, we managed to mitigate 828 safety issue, and then there's 188 potential hospital readmission avoidance. 501 hours of GP time is saved, which is equivalent to, I can't even say that number, quite a lot of money, I think. Yeah. And then medicine waste reduction and cost savings was 1,287. And also the data use that we found has been used to help form other improvement initiatives within the Cardiff and Cardiff and Vale University Health Board. So I'm now part of a DAL working group that we're looking at issues and how we're going to move this forward. And then also we managed to done like a news item on the SharePoint and as a screensaver. And there's also like an SPA action plan being done for clinical boards. And then we had some issue with DATEX reporting. So we're going to start a pilot on cluster pharmacists reporting DATEX. So there's a lot of there's a lot of things can be moved forward. And also we have like positive patient and colleague feedbacks. So key conclusions: improve efficiency and streamline process, enhance patient safety, which is what we are all about, what we care about. And then also it reduces the workload for surgery staff, GP, and even community pharmacists. Because by us doing it, we actually make sure we contact the patient, contact the relevant, like, care agency, community pharmacist, and then make sure the prescription is done rather than, pass it to the GP. And then it's also show that it's like cost saving and reduce medicine wastage, and then also patient and staff satisfaction. So one of the patients said, "Thank you for stopping me from taking the wrong medicines. This call has been the best thing to happen to me since my discharge from hospital." And then we had some like colleagues, service users from even feedback from like community pharmacists, admin, GPs, like time and cost saving, effective. And then they thank us for a thorough and comprehensive service, and the issue were addressed promptly and patient safety ensured. So next steps, we require your help. So we were hoping that we can engage and support other clusters or even other localities to spread and scale of this new model. And we're hoping to use this to expedite the DAL issues to a wider stakeholders to ensure collaborative efforts to address the challenges and improve patient safety. There are a lot of challenges, but by us working together, we definitely can help to improve the patient safety. And then also staff education and training. Hopefully we can liaise with HEIW and Health Board to raise awareness and promote best practices. So any questions?
Oh, Ivana, that was awesome. I just love that. It appeals so much to me in terms of finding a process that's just not working for patients or for the system, and then getting ahead of it and getting upstream and preventing a load of unnecessary processes and improving outcomes. I just loved it.
Completely. No, it's really, really exciting. Is why haven't we done it earlier? Do you have a sense of that?
I think it's because probably because cluster pharmacists is a very new role. So I'm one of the first cluster pharmacists like back in 2015. So all these traditionally all these medrec was actually done by surgery staff. So we have community pharmacists. Previously in community pharmacy, you've got hospital pharmacists, but primary care pharmacists who actually works in GP land is quite a new concept. Well, not new anymore. It's been like nine years. So I think by introducing us into the primary care and actually working in GP practices, not just in PKIC like offices and things like that, it actually helps. And then it shows that the collaboration, between like the Alive Healthcare actually help in this sense. And so it happened as because our cluster wanted to do like a care hub. So not only this is only part of it where we do the medication bit, but we also have OT in our care hub, which helps looking at the social side and things like that. We have well-being connector. So all this is a part of like a holistic approach. Yeah.
Which then improves adherence and outcomes that way. I guess a nagging question for me is when you take, it's all about relationships and it's about understanding the way your clinical colleagues prescribe. Has that been a challenge? Has it been a challenge linking in with the hospitals? How does that communication work?
I would say that is definitely a challenge, and also a challenge that we've been facing for quite a while, because I think like what Dr. Kosh said, IT system, they don't talk to each other. So and then you can see from the presentation, one of the biggest issue is actually the DAL issue, the hospital letter issue, that we either don't get it or there's not there's incorrect information. There's a lot of communication issue there. So I feel like this Bevan Example project has actually definitely given us opportunity to actually, now we are hoping to create more awareness and then to bring this up to the hospital and like and see how we can work together, because it's how we need to work together, isn't it? Because this is a time when the patient is very vulnerable, and things can change when there's like changing of care, transfer of care between like different sector. Yeah.
And it sounds to me that you probably have a lot of telephone time just tracking people down. How do you keep your energy going through that? And then how is that built into the process? Because obviously this is something that with time one would hope is that an IT solution would come, but for the meantime, how do you keep it going?
So I mean, personally, I love it. So I'm like, I don't know. I feel like, these patients are, they a lot of them are quite sad, or like, are vulnerable. So if we can do something, and also that's the ethos of our Cardiff Southwest cluster, to actually try and help, not just medically, but in the whole process. So I think because we share that ethos, and then like it's that, and then also because I think we just have to persevere, and now I'm very excited because after so many years, finally other people are listening, like we managed to get other clusters involved, and then the hospital actually said like they never knew about all these things, because if we don't feed it back, the hospital wouldn't know. And also we talk about the DATEX reporting, because we had problem in primary care that it's not as easy to report DATEX. So I think by this project we actually can work together.
Yeah.
Ivana, so I work in a hospital, and I write discharge summaries for patients. And I would like to know, the nub of this project essentially is that there is information going from hospitals into primary care, usually prescribing information, which is either incomplete or contains errors in it, or it has some other sort of inaccuracy. How can we reach a place where the quality of information we're sending to GPs is better?
So I think this is a complex piece of work. Then that's why the DAO working group it's trying to achieve this, because number one, there's the IT issue. There's a lot of DAO which are still sitting as draft on clinical portal, on Welsh Clinical Portal, and hospitals thought we could just go onto clinical portal to have a look, but actually GP can't see them. So by having us, having meeting like this, the working group, that can be fed back. Actually, IT needs to, there's a way to notify that the doctor hasn't signed off the DAO, things like that. Okay. And then, for example, quality of the DAO, that's why PICIC or like primary care is trying to help with like training or things like for junior doctors or pharmacists to try and create raise the awareness or importance to write a good DAO discharge letter. And then also maybe we were hoping like better communication between primary care, and maybe a way to get in touch with the ward or clinical board. If let's say we find some issue, then we can communicate with them better to actually resolve the issue, because everybody are very busy, and then it's quite hard. We don't really want to bother the consultant or bother the ward, but if we can have a way of communicating better, it would be good. And then like what we do in the hub as well, we give our number out to hospital, to pharmacy, and said if there is any problem with patient post hospital discharge, please get in touch with us. So that is also like a two-way thing. Yeah.
It's very considerate of you to not want to bother the consultants. But I would suggest that if you did bother the consultants a couple of times, the quality of discharge information might dramatically improve.
We do, because we do email the consultant as well, and then it's just trying to trying to work out a best way of doing it.
I absolutely agree. There's quite a few questions have come in, and I had a question myself, Ivana, and one that Zoe Hilton wanted to ask, which may be similar. But my question was, who funds your role? And Zoe's question was, in what way did the Bevan Commission give you support?
Okay, so who funds our role is come from cluster funding. So we are already cluster pharmacists employed by the health board in the cluster. So this is not a separate work. So basically, we just when I got first introduced to this role, we were doing more like reviews and stuff in individual surgery. But when COVID hit, we found that it's important to do like a collaborative work. So therefore now our pharmacist time is divided between doing DAL, but also we still run like NOAC clinic, polypharmacy review clinic. So it's part of a cluster funding. There's no extra funding for this. In terms of Bevan Exemplar, again, they have actually helped us a lot with like probably project management and things like that, and also opportunity like this. And then we are going to present this at the Senate on the 13th of June. So hopefully to actually bring this a bit forward. Yeah, but money-wise, funding-wise, it's already what we're doing. Yeah.
Can I just add to that, which is, is there a gain share for the hospital? So how do you get to change their practice if they're not funding this? Are they funding?
No. So this is the challenge. This is the challenge. I don't want to say issue or problem, but it's a challenge because the project, we do it all from primary care point of view. And then it is actually quite hard to try and get secondary care on board. Yeah.
Because you're already showing that there's reduced readmission, which then means that the hospital then is making a saving. I know I'm playing devil's advocate here, and it's how do we make this sustainable? But also some of this is what you're talking about is a culture change. And so we need that engagement.
Yes.
And so a slightly more detailed question, Ivana, so I'll try and pick out the key points. But Shuan Menas has asked a question, and she's just wondering, when you advise patients and you decide what medicines they're going to be taking or what the way forward is with their medicines, do you also talk to them about things like lifestyle, exercise, nutrition, addictions, things like that, and how it might be possible to reduce reliance on medicines through those avenues?
Right. Okay. So we are concentrating more on the medication bit and the patient safety. So I think we use a lot of our clinical judgment in terms of make sure the dose is correct. And then things like if, let's say, a patient's being put on a blood thinner and things like that, we do try and counsel them and things like that. And then we will cover sort of smoking cessation, exercise, not generically, okay, but if there is a chance, because not only we call them, because we also have our integrated care navigator, which they will call the patient to do a well-being check after our phone call. So that's a different part. It's not part of this project, but it's part of what cluster do. So they will then go ahead and ask about adaptation around the house, social need, and then that kind of thing is more covered by them. Whereas I think what we are doing is more ensuring the patient is taking the right medication, ensuring that there's no interaction, or ensuring the repeat is being updated properly. And also there's a lot of issue, like if there's any clinical issue, we are the one who try and get in touch with the consultant hospital, trying to sort those issues out before passing it to the GP. And also, like for example, if they are started on a blood thinner, but there's no follow-up on CAF portal, no appointment, we try to then try and explain to the patient, make sure they go and attend an appointment or chase up an appointment. If there's no appointment, we get the GP to write via WCCG to check whether there's an appointment. So I think a lot of our time are being used on this. Yeah.
Yeah, but what I'm taking from that, though, is linking back to something you said earlier, is that you operate in a system in Cardiff Southwest Cluster, which is really, really focused on preventative care, about using an interdisciplinary approach. And so I know that that cluster is involved with social prescribing as well. So there are members of your team, your wider team, who are actively engaged in those sort of preventative measures as well, I believe.
Yes. Yeah. Social prescribing. Yes, we are all about social prescribing. So I would say, yes, we will cover it, but it's mainly done by ICN. Yeah.
Okay. There is so much fantastic feedback from our community in the chat box about both of your talks, and about how enthusiastic everyone is. I was just going to connect you too, because I think you probably have questions for each other, and I just wondered, Isla, whether you had a question for Ivana or the other way around, because it seems to me that you could both be connected, or maybe you are already. Did either of you have questions?
We're not connected already, but from my point of view, pharmacy or health inclusion pharmacy would be a fantastic part of a health inclusion model going forward. So, and I know we're in contact with pharmacy colleagues about that. So Cavis isn't part of a cluster. We're obviously a health board managed service, even though we're primary care, but we're not part of a cluster. But the work that you're doing with discharge advice is, I mean, it's exactly what we see every day with our patients as well. So I would be keen to hear a little bit more from you, if that's okay.
Definitely,
not right now,
definitely.
outside.
Yeah. Sure. Yeah.
Well, Nick, it's probably that time of the day where we need to start bringing all the different threads together. Yes. Any particular take-home points that you've taken from the session today?
I think I always say is about how holistic all of this is, and there's not one single solution. It's multiple solutions and passion to get the job done. Is, no one's going to wait for you to do either pieces of work. You just have to get on and do it, and then bring through that energy. Then, and the reflection that I'm hearing is then constantly reiterate the service and thinking ahead. So, fantastic. Both. This has been a really exciting. So I'm really glad to be part of it. What were your thoughts?
I loved it. There's nothing I love more than talking to people who are passionate about their services and making a difference. And it was fantastic. The common themes, I think, getting things done early, so not waiting for a problem to happen, but moving upstream as far as possible. Getting it right first time. There's, in value, the roots of value in Wales are going back to sort of prudent healthcare and choosing wisely, and even before. And those threads they're coming through in what both Ivana and Isla are doing, and just how to get things done. So, Ivana, you've been in the service since 2015, so 9 years, and you're in an environment where innovation flourishes already. So it's quite fertile ground for doing the kind of work you're doing. And Isla, I love how you did your assessments, identifying that need, and then building your community of the willing, or your coalition of the willing around you to get behind the work. So, yeah, lots of themes for me, Nick. And so probably then from Nick and I, it's just an opportunity to say thanks so much to Isla and Ivana for joining us.
Yeah, and so we will have another Healthcast on the 24th of May. So normally it's the last Friday, but the last Friday is a bank holiday, I think, or during the half term. So we've brought it forward a week just to let you know. All of this, it will be available online. I'm going to go back and listen to it again, and hoping that I can meet both of you, because there is so much that we need to share through pediatrics. Sometimes there are lots, and there's many other issues to discuss. So thank you very much to both of you.
Yeah.
And to Dave.
Oh, thanks, Nick. See you next month. Cheers, guys.
Cheers, guys.